Hi, my name is Suresh Nath Newpani. I am a Urban Studies Institute PhD candidate here at Georgia State University, Atlanta, Georgia. The title of my presentation is Racial Residential Segregation and COVID-19 Mortality. COVID-19, the global pandemic, has already claimed over 988,000 lives here in the United States, with over 6 million worldwide, and more than 80 million confirmed cases just in the United States. And various studies in the past have shown that minority population bear the greatest burden of the impact of a range of diseases. So, racial minorities face a higher risk of chronic illness. Thus, it is important to examine if structural disparities, such as residential segregation, are making people of color more vulnerable to COVID 19 mortality. So, as Massey and Denton suggested, conventional theories have ignored segregation as a predictive factor in such health disparities. So, for any health inequities in health research, it is important to consider the social position of individuals because that impact or shape everyday life conditions and vice versa. So, race is an important predictor because it has been used as a predictor in population health research over the past few decades. So, black compared to whites, patients with the COVID 19 experience 1.4 times the risk of hospitalization, and higher infection among black and Hispanic population, as well as communities with a higher densities of minority population, have already shown that it has a disproportionate impact on minorities. So one important thing that we cannot ignore is the underlying health condition, which is associated with the socioeconomic status. And as socioeconomic status itself is associated with reduced access to healthcare, poor diets, hence vulnerable to COVID-19 comorbidities. So in this particular research, I'm not focusing on the underlying health conditions or lower socioeconomic status, except I'm going to use income inequality as a predictor to see if it is associated with the COVID 19. But the main variable here is residential segregation, which is associated with a larger system of inequality that has impacted minorities. So, health inequities and health inequalities, these are two intertwined factors that shape the population health. So, health inequalities are disparities in health outcomes among groups such as race and gender. That's why it is important to consider race and gender as a predictor. And health inequities, structural inequalities stemming from prevalent injustice. So, structural inequalities are also important factor that we cannot ignore. So, we are taking segregation as a structural inequalities, an example of structural inequities here. So, such inequalities and inequities are correlated to socioeconomic status of individuals and race that are used as crucial measures in predicting population health outcomes. So, various research studies in the past have already shown that. This paper examines whether there is any disparity in the impact of COVID-19 pandemic on racial groups in segregated areas. So the research question is, what is the effect of racial residential segregation on the racial disparities in mortality caused by COVID-19? So there are three hypotheses I proposed here. Black living in black individuals are more likely to die of COVID-19 than are whites and other races. Racial residential segregation will explain and therefore attenuate the COVID-19 mortality gap between whites and black. In other words, I'm proposing on this hypothesis that even whites living in segregated counties have higher chances of dying of COVID-19. That's why the mortality gap will be less. Black individuals living in segregated counties are more likely to die of COVID 19 than black living in less segregated counties. This is a cross-sectional study. Um, I got the data from CDC. It's a restricted data. Upon request, filing an application, CDC allowed me to access the GitHub portal, and the data was from January 1st, 2020 to April 15, 2021. And the dataset may include some vaccinated individuals. As we all know, FDA issued the first emergency use of vaccines in early December of 2020. So segregations are high level of segregation are found among different urban spaces. So central fringe and medium metropolitans with high level of segregation, so they could mask over non-core regions. That's why I had to remove non-core rural areas from the data set. So 1,341 non-core rural areas were removed. So the total data set had 23,723,384 observations. And when I removed the rural areas, I had to remove more than 1 million observations. And there was a data loss due to that. With the data loss, 8.5% represented white individuals, 4.3% of them were black, and so forth. And there were many non-responses in the data set. So race is an important variable, and that had the most missing values, nearly 8 million observations. So I had to remove those observations that did not have information about race. So removing everything, the data set was reduced to 8,668,744 for the analysis, which is around 63% of the data loss. So the construct is COVID-19 death as a response variable, while segregation, race, income inequality, gender as predictors, and controlling for age and population density. So the segregation index is a county level index along with income inequality and population density. So all of those data, I got it from Robert Wood Johnson Foundation. So for the segregation index, dissimilarity index was used, the popular Duncan and Duncan's classification of dissimilarity index. So the segregation index was non-white to white, ranging from 0, a complete integration, to 100, complete segregation. For instance, a score of 0 indicates both groups, whites and non-whites, are completely integrated across all census tracts in that particular county, whereas higher scores indicate a higher level of segregation among census tracts within that county. And segregation index was mean-centered to improve the interpretation and model parameters. Race were white, black, Hispanic, Asians, and others. Others included American Indian, Alaska Native, multiple others, Native, Hawaiian, other Pacific Islander. They were dummy coded, making each race as individual variable. Income inequality, I got this data from Robert Wood Johnson Foundation. It was based on ACS 2015-2019 estimate. It is a ratio of median household income in 80th percentile over 20th percentile in that particular county as an index. So in other words, higher the income index value of income inequality, the greater the gap between individuals living on the top and the bottom end of the group. The control variables, like I said, is population density, and the population density was positively skewed, so I had to log transform. I used the hierarchical logistic regression. So multi-level regression showed that if residential segregation is associated with the individual level outcome of mortality, adjusting for both county level and individual level confounding factors. So this study used SLR with a binomial response variable, death caused by COVID-19. Death, yes, 1, no, 0. So race and segregation interaction term was used to examine if the likelihood of race segregation impact on COVID-19 death. So, in other words, white living in segregated counties, likelihood of dying of COVID-19. So, SLR model with a random county effect was done to satisfy the violation of assumption of independence. The health outcomes of individuals living in the same areas or county may be correlated because there were mask mandate, lockdown restrictions, so people living in the same counties may have some kind of similarities. So that's why a random county effect was used. I used our statistical tool and LME4 package to run the SLR models. The model was a Bernoulli distribution where Y is COVID-19 death and pi is the probability of death. So the random intercept model, the level 1 variables, I will explain all these independent variables in the next slide. And level 2 models, which includes all the individual level demographic variables, plus the county level variables such as segregation index and population density. So based on those two equations, 3 models were produced. Model 1 with the individual level variables with gender, race, and age, the GLMR function, the death and random county effects, and a binomial logistic function. Model 2 included all the variables from Model 1 and segregation and income inequality and population density, the county level variables. And the third model has the interaction terms along with the variables from Model 1 and 2. This is the descriptive statistics. The table shows the mean death was 0.04, and the percentage of total death was 4%, which is pretty consistent with other studies. COVID-19 death rate was 4%. 56.6% of them were male who died, and white represented the largest population who died of COVID-19 with more than 58%, followed by Hispanic, 19.45, and Black. Interestingly, the proportion of death was different, with the Black having the highest proportion of death with a 0.54, followed by whites 0.51 and Asians 0.45. Hispanics had the lower proportion compared to whites and Black and Asians. This is the correlation matrix showing individual correlation with among the variables here. I ran this multicollinearity VIF shows that all of them are below 10, showing that there is no issue with multicollinearity. So there are 3 models produce these regression tables here. Model 1, like I said, has individual demographic variables. Model 2 has segregation, income inequality, and population density added, which shows that segregation is associated with 1% more likely to die if somebody lives in segregated counties. Income inequality has no effect, so it is not statistically significant. And population density, as expected, 38% of people living in highly populated areas, with the area with a high population density, are likely to die of COVID-19. The third model, slight changes, but not much as compared to Model 2. Now, in the third model, Black has the Black population. It has more, like a 20% more likelihood of dying of COVID-19 than whites. Hispanics have lower, 14% lower chances of dying of COVID-19 as compared to whites. Asians have 7% more likelihood. And the interesting thing is segregation itself is associated positively, statistically significant, meaning 1% more likelihood of dying of COVID-19 if they live in segregated counties as compared to non-segregated. But if it was interacted with the individual race, was not significant. So Black living in segregated counties has no effect with COVID-19, with the odds ratio being 1. It was different for Asians, and for others it was 1% more likely. And I chose model 3 based on this chart with log likelihood. Um, and this is the figure that shows the odds ratio. Easy to see the different odds ratios. So this study shows that racial residential segregation is significantly associated with the higher COVID-19 death. And there's a positive correlation between segregation and COVID-19 mortality, and minority population bear the highest burden of mortality as compared to whites, with 20% more likelihood for blacks to die as compared to whites. And Hispanics have 14% lower chances and likelihood of dying of COVID-19 than whites. And this also supports the so-called Hispanic paradox narrative, which suggests that despite their lower socioeconomic status, Hispanic communities have an advantage over various health outcomes compared to other minorities or even whites. So, hypothesis 2, segregation will reduce the COVID-19 mortality gap between whites and black. This was not supported because the odds ratio was 1. The exact same thing with the Hispanic, no group effect on segregation. But for Asians, as the segregation increases by 1 unit, the probability of mortality declines by 1%. And the results show segregation has the same impact on whites, blacks, and Hispanics with respect to COVID-19 mortality. Hence, hypothesis 3 is not supported. So, since segregation is associated, but individual interaction terms with the segregation was not associated with the COVID-19 mortality, I argue that more confounding factors are needed to be considered in doing further studies. A multidimensional approach is needed to understand the association with the segregation and COVID-19 mortality in the future. This is my conclusion. Blacks and Asians are more likely to die of COVID-19 than whites. Hispanics are less likely, and it supports the Hispanic paradox of being belonging to minority community, but still having good positive health outcomes as compared to whites and other minority groups. And racial residential segregation is a predictor of COVID-19. It is statistically significant, even though the likelihood was 1% more than people living in less or non-segregated counties. But it is predicted. It can explain the COVID-19 mortality. Thank you so much.